I can start now.
Dr. Heba, I think we can start.
Yes, okay. Hello, everybody. It's me. I am Dr. Heba Mansour. I am an Egyptian ophthalmologist, and I came today to share with you my experience, not only in the exam day, but also during the journey to the exam. Actually, I owe a lot to Dr. Shakur, who added me to the study group for candidates who were going to the exam last February. Until this moment, the idea of appearing to the exam seemed impossible to me because I have a lot of challenges. I am a mom for 3 kids. 2 of them are toddlers. One was a baby, 6 months old at this point. And the second challenge was that I had stopped practicing clinical ophthalmology 3 years ago after 5 years of experience during the training in the Egyptian fellowship program. So it is actually not so big experience enough with also a long break after. Anyway, I started to join them in their daily night meetings and listen to their discussions and share with them the same stressed moments till the exam. And also I shared with them the dream of passing the exam. So I had the same dream. I want to pass the exam now. And to pass the exam, I have to appear. So I decided to do, regardless of my challenges. I hired an direct ophthalmoscope and I started to go to public clinics. I started to see cases. I started to practice proper clinical examinations that I had to be well trained before the exam. And also I started to look for a study partner to make me commit to studying every day. And after several trials, I found a very smart and brilliant study partner, Dr. Fathy, who shared the journey with me till the end, and she passed also. Every day at the morning, we read from Kanski, and after that, we went for clinics to see cases. And at the evening and night, we study with the big group, a lot of members, a lot of amazing members, and a lot of candidates. We were about 20 candidates who were studying together, practicing the past experiences and discussing every night. And I think this was the key of success, the commitment and consistency every night, every day and the night. We didn't stop till the day of the exam. And even in the day of the exam, a group of us decided to book the same hotel. And at the exam night, we revised together some topics that we can meet the next day. Actually, this was relieving our stress when we studied together at this hard night. Then we went to our exam, and alhamdulillah, I have passed my exam on my first attempt. A deep of thanks to my professors in the Dr. Muthusami Academy. I joined the academy in 2023, and I attended a lot of mock exams, almost all the mock exams from last February till my exam I attended. And I try to be active and share and participate in the sessions. And also in late night, I can play a video, watch a video for all the mock exams and all the lectures in the channel of the academy. So deep thanks to Dr. Koshek and Dr. Muthusami and Dr. Gheda and all professors who helped us a lot. The exam construction is about 2 days, Viva day. In Viva day, there are 3 stations. Each station is 20 minutes with 2 examiners, each of them with 2 examiners. They can give you written case scenarios or photos for clinical case or investigation, or can give you an oral questions. The second day was OSCE day. For me, was the second day. 4 stations. Each station is 12 minutes with the 2 examiners in each. And you need to examine at least 2 cases. If you can examine more, it is bonus points. You can compensate if you failed in any case. After that, you can compensate by the bonus points you get in this station. Sources of study, mainly I studied from Kanski, but some topics actually is better in Oxford. So I studied mainly from Kanski, but I added some topics from Oxford, especially the management. In some questions written better in Oxford. And the book that I like very much, Practical Wound, this book with cases and photos. This book is very nice, and also this white Wong for examination review is very good also. Showa book is very important. You have to read it at least once. And I read General Medicine from Dr. Walid Badr notes and some notes from Oxford for General Medicine, and plus Dr. Vijaya lecture. Actually, Dr. Vijaya conducted a lecture with us about 4 or 5 hours. What very, very nice, precious lecture. We depend on it on our exam, all of us. Also, YouTube videos and lectures, especially Dr. Musosemi channel, and our study group meetings with amazing colleagues. Okay, the first station was General Medicine and Neuro. And there was 2 examiners. I met 2 examiners. One of them was Englishman and the other was Egyptian. And he gave me a written scenario of 23-year-old female with nausea, vomiting, and bilateral disc swelling, body mass index of 30. He gave me this scenario and he asked me, what's your diagnosis? I started to put a differential diagnosis before I am going to the diagnosis, which is benign idiopathic intracranial hypertension, but the examiner stopped me and he asked me again, what's your diagnosis? I told him my provisional diagnosis will be benign idiopathic intracranial hypertension after exclusion of other causes. He told me, what are the symptoms of benign idiopathic intracranial hypertension? I mentioned nausea, vomiting, morning headache, whooshing sound, blurring of vision, diplopia. He told me, okay, what is the investigation required? I told him MRI. He asked me, what are the findings of the MRI in this case? I told him, the importance of MRI is to exclude if there is any space occupying lesion and if there is any cavernous sinus thrombosis, and if it is a case of benign idiopathic intracranial hypertension, we can find slit ventricles, flattening of the sella turcica, empty sella turcica, and he asked me what else. I answered lumbar puncture when I find that the opening pressure is more than 25 centimeter. He asked me, what is your management for this case? I told him that I will manage this case in collaboration with the neurologist, because he is someone who will mainly manage this case, but I'll counsel the patient to reduce her weight, and I'll follow up the patient by colored photos for the disc and also OCT. And also I can do visual fields. And also, and as for the neurologist, he will give the patient Sidamex or steroids, or he can go after that for repeated lumbar puncture, or after that he can go for shunts, for doing shunts. Like this, the discussion was like this. It was a ping-pong discussion. He didn't let me to tell him a lot of information without stopping me. He moderated the discussion. Okay. a written scenario of a patient who is going to cataract surgery, and he has developed the atrial fibrillation. He asked me about the causes of atrial fibrillation. I started to test them, cardiac causes and non-cardiac causes. Cardiac causes like hypertension, like valvular diseases, like MI, myocardial infarction, and then cardiac causes like pulmonary embolism and thyroid, hyperthyroidism. He asked me what are drugs that used to control this condition. I told him that we need to control the rhythm and control the rate, and also to give anticoagulant. We can control the rhythm by amiodarone and control the rate by beta blockers and calcium channel blockers. And as anticoagulants, we can give low molecular weight heparin, warfarin. And he asked me what else. I told him we can give direct oral anticoagulants. He wants this answer. He wants to tell him this direct oral anticoagulants. Then he asked me, okay, how will you manage this patient or a patient on anticoagulant who will go to an ophthalmic surgery? I started to say that I'll counsel the cardiologist about stopping the anticoagulant, about the need of stopping the anticoagulant before the surgery and how many times you need to stop it. And also according to the type of surgery, if it is cataract or it is squint surgery, we can keep INR below 3, but if it is oculoplastic surgery or glaucoma surgery, we need to keep INR below 2. And also he asked me what else. I stopped for moments. He told me that you need to counsel the anesthetist, and because he can give you options of the types of anesthesia instead of giving the patient injection anesthesia, like peripulpar anesthesia, you can give topical anesthesia. Okay. Then he asked me about what are the causes of intermittent epilepsy. I answered myasthenia gravis and also early thyroid eye disease, and then I stopped. I forgot about all other causes, so I wrote them here: multiple sclerosis, cranial nerve palsy, partial or resolving or microvascular causes, or orbital mass or fatigue. All of these are causes of intermittent diplopia. Then he went back to myasthenia gravis and asked me, how can you diagnose myasthenia gravis? I told him from the history and also from my examination, I can do IcePack test, I can do. Am I audible? Am I audible to you all?
Yes, yes.
Yes, okay. Fatigability test, Kogan twitch sign. I can take muscle biopsy, single muscle EMG. He asked me, and lastly, I told him tensolin test. He asked me, you know, tensolin test is an old test and we didn't use now, but please tell me how can you do tensolin test? I started to mention I'll give the patient 0.3 atropine intravenous, and after that, I'll give him 0.2 atropine intramuscular, and I'll give him 0.2 from. Then I forget about hydrophonium chloride. I forget the name. I told him, yeah, there is a drug I give to the patient, but I cannot remember the name now. I don't know how I forget the name. I forgot the name at this moment. And he told me, okay, I'll tell you the name. It is hydrophonium chloride. Yes, I told him, yes, it's hydrophonium chloride. I'll give the patient 0.2. And I'll wait for 60 seconds and I'll see if there is any improvement. I'll stop the test. And if there is no improvement, I give the patient the last 0.8 milli of the drug. And I need to measure the doses before and after the test. Also, I need to do test screen, and I need to know that the test is will last for 5 minutes. He told me, okay, tell me now about the causes of 6 nerve palsy. I started to list all the causes of 6 nerve palsy, but I forget to mention the most important cause, which is vascular causes. So he was seeking for this cause. He was seeking to say vascular causes. It is the most important cause for 6 nerve palsy. I mentioned increased intracranial tension, trauma, multiple sclerosis, tumor, even the syndromes of 6 nerve palsy I mentioned about. But I forgot totally to mention about vascular causes and diabetes. Then he told me vascular causes. Yes, I told him, yes, vascular causes. He told me, what is the importance of differentiating vascular causes from other causes? I told him, because in vascular causes, we need to do no intervention. He told me, why? You will give the patient the prism, you will occlude the eye, you will can use botulinum. Why no intervention? I told him, okay. So I stopped. He told me, what about counseling the patient? I told him, yes, here in vascular causes, the patient will improve after a while. While in other causes, we need to screen and manage the cause, and maybe the patient will not improve. And then he asked me, what is the importance of the age in this condition of 6 nerve palsy? I told him, because the age, with the age, we may think in different causes, because in the childhood we can think in meningitis or in tumor, or rarely congenital 6 nerve palsy, while in middle-aged patients we can think in multiple sclerosis mainly, or trauma. And in old age, we think in tumors and cerebrovascular causes. He told me, okay, and he gave me a written scenario of a case of 18 years old healthy female with left hyperphoria, 10 prism diopter, and head tilt is turned to the opposite side. He asked me about the diagnosis. I told him it's mostly left fourth nerve palsy. He asked me about differential diagnosis. I told him inferior oblique overaction, and I stopped answering. He gave me a pen and a paper, and he asked me draw, and you can reach the answer. I didn't use the help actually. I started to mention, okay, maybe problem with inferior rectus, maybe in the superior oblique overaction. He was unsatisfied about my answer. I told him Brown syndrome. He told me no. If Brown syndrome, he will be hypo, not hyper. Okay. He asked me after that, how can you know that it is a long-standing condition? I told him she is a healthy female with a large 10 prism diopter, is a large fusional amplitude, vertical amplitude, and also she gained abnormal head posture. He told me, okay, then how can you diagnose and measure strabismus? And I started to say, yeah, I'll do Hirschberg test to measure the angle roughly, and I can do alternate prism cover test to measure the angle by the prism. And I am going like this. He stopped me and told me, look, it is the last time I give you a help. Tell me, what is the test, specific test used to measure the strabismus? I told him it's his screen test. He told me, okay, how can you manage this case? I told him we can do inferior oblique quickening or recession. And also we can, for exocycle torsion, we can do Harada procedure. Then he gave me a written scenario, another written scenario of middle-aged female with failure in left eye adduction in horizontal gaze in the case. And he asked me about the diagnosis. I told him the diagnosis is left internuclear ophthalmoplegia. He asked me the most common cause in this age group. I told him multiple sclerosis, and he asked me about the causes in old age. I told him vascular causes and tumors. And he asked me about other mimicking conditions. I told him thyroid eye disease and myasthenia gravis, and also partial keratitis palsy. Now it's up for general medicine. I finished answering before the bell rang, and he told me to wait until the bell rang. And I went to the next station, which is anterior and oculoplasty station. There are 4 minutes, like a break between the station and the station. You go to like a corridor, and then you come back to the area that the examiners stay with. And when I was so stressed and anxious, and it was obvious, the anxiety was obvious. The examiner asked me to keep calm. There is no worries about anything. Please take a deep breath and keep calm. I did. And he asked me an easy question. What are the causes of neuropupil before cataract or during a cataract surgery? I answered long-standing diabetes, long-standing uveitis, pseudo-exfoliation, old age, all of causes. I think I mentioned all of causes. Also, posterior cyanosia. He asked me what are the complications of neuropupil. I told him bad visualization can cause any complication like extended rhexis, like dropped nucleus, posterior capsular rupture, and dropped nucleus, vitreous prolapse, and all of these complications. He told me, how will you manage? I told him I can start before the operation. He stopped me and asked me to tell him intraoperatively how I will manage. And asked me, tell me, how can you dilate the pupil in the, what are the drugs you give in your ordinary surgery? I told them, like, Mydravir, or Mydrasid, tropicamide, and the epinephrine. He told me, okay, then how will you manage intraoperatively? I started by medical. I'll give anterior intracameral epinephrine, and I'll also use viscoelastic, and I can use iris hooks, my healing ring. She kept asking what else. I didn't know what else actually. I mentioned all. I told her yes, sphincterectomy, and also I can do iridectomy, but I don't like to do this. She asked what else. I didn't know what else. She asked what else less invasive. I didn't know what she wanted actually in this question. Then she asked me, how can you know that there is a posterior capsular rupture in the case? I answered this question. Anyone know? How can we know that there is posterior capsular rupture? Hello?
Yes.
Yes, can you answer? Yes, can you answer? How can we know that there is posterior capsular rupture?
Yes, suddenly there is changes in the depth of anterior chamber, maybe more deep, and your phaco
Yes.
tip will be not efficient in
Yes.
phacoemulsification, and also sometimes maybe there is irregularity in your pupil due to vitreous
Yes,
stress.
there is vitreous prolapse, yes.
Yes, and you can see it directly.
Yes, you can see it directly, exactly. And if there is loss of some nuclear fragments from the view, right? And the slight dilatation of the sudden dilatation and then construction of the pupil, sudden deepening of the anterior chamber, as you mentioned, all of this. Okay, he asked me what are the complications of dropped nucleus. I told him it can induce cystoid macular edema, it can induce traction and limited detachment, it can induce vitritis, inflammation, corneal edema. Then he asked me, so how will you monitor the patient till he goes to a vitreoretinal surgeon? I told him, okay, I keep my eyes on the IP. I monitor the posterior chamber and look if there is no view, I can do the scan anytime. And I'll give the patient steroids, antibiotics, and also local steroids and antibiotics, and also IUP lowering drugs. He told me, okay, and he gave me a photo of large lower lid mass in old age patients. The photo was like this. It was not the same exactly. It was more large than this lesion, but it was barely margin with telangiectatic vessels and old age man. And he asked me to describe. I started to describe the lesion and mention about the size, dimensions, the telangiectatic vessels, the matarosis, the eyelid position, all of this. And he asked me about the management. I told him that I need to do excisional biopsy and we can do Mohs surgery. And then he asked me, then after Mohs surgery and after you excise tumor, I told him I need to reconstruct the eyelid if I make sure that I took all the safety margins. And I am sure that we are free of the tumor. She asked me about how can you reconstruct the lid. I told her about Hugh's procedure that like we can take a flap from the posterior lamella of the upper eyelid. She asked me, what if the patient doesn't like to close his eye? I told her, I stopped for a moment. She asked me what for the posterior lamella. What will you do for the posterior lamella? I told her we can take a graft from the hard palate and she was satisfied with my answer. And then we went to the next question. Here they gave me a picture of an old age with actually in the exam it was left intraocular, and there was a stain and inferior keratitis. The cornea is stained inferiorly, and lower lid appeared bulky like the right eye in this photo. Okay, and they asked me to describe. I described everything in the photo, and I mentioned that I can see that is an old age, and I can see stain, and I can see keratitis, and all of this. Okay, and he asked me about the diagnosis, and I told him that my provisional diagnosis will be that is senile intraocular. Mostly overlapping of the pre-septal over pre-tarsus portion of the orbicularis muscle due to I see this because of this bulky appearance of the lower eyelid. He told me, okay, how will you manage this case? I told him, firstly, first of all, I'll treat this keratitis, and then I protect the cornea by contact lens and excessive lubricants, antibiotics. Also, I need to do tapping to the lower lid, or I can go for everting sutures. And I describe the sutures, how can it is done. And we can, if there is lid laxity, I can do a quicker procedure. He stopped me, no, enough, no need to mention about more surgeries. And he went to the next question. He asked me about if there is a patient of severe bacterial keratitis, how will you manage this patient? Actually, I didn't manage this question. It was an easy question, and I didn't manage it well because I rushed to mention that I give the patient do a therapy of fortified antibiotics, and he, okay, what are fortified antibiotics you will use? I told him ceftazidime and also vancomycin or gentamicin. He told me, okay, so you cannot use monotherapy? I told him, yes, I can use what type of monotherapy? I told him fluoroquinolones. He told me, what is the frequency you can give the patient? I told him, I can give every 5 minutes for an hour. Then I can give every an hour during the patient is awake and during sleep also. And after that, I can reduce the dose during the sleep, make it at the day only. He told me, then what will you do? I told him, okay, I will follow up the patient. He told me, okay, so you will follow up the patient. It means that you will let this patient go home. I told him, no, if this patient can instill the drops to himself and the ulcer will not go to perforate, okay, I let him go home. But if there is indication of hospitalization, I think it is a big mistake I did. I need to start my answer by hospitalization. And then I can say that I will take culture and scrubbing, and then I will start antibiotics. It's a mistake to start answering this question by I will give the patient. Okay. But he turned this discussion as much as he can to improve my situation, actually. Then he asked me about the complications of severe bacterial keratitis. Anyone know? What are the complications of severe bacterial keratitis? Anyone can answer? Hello?
Yes, it can cause corneal perforation, endophthalmitis,
Yes, yes, exactly.
and it can lead to panophthalmitis.
Also, yes. Corneal scarring, vascularization, right? Okay. Then he asked me, what if it is resistant to treatment? What if you see the answer after 48 hours and there is resistance to treatment? This is an easy question. Can anyone answer? Can anyone answer? What to do if the ulcer resistant to treatment after 48 hours?
Yes, I can stop antibiotic and rescrape again or do corneal biopsy.
Yes.
Yes. And then
Exactly.
restart. Yes, restart antibiotic again, waiting for result.
Yes, and you can revise the culture, the old culture reports, if it is if there is another antibiotic that come in the reports that the bacteria is sensitive to it, you can give this antibiotic if you didn't start with it. So I actually I didn't answer like you. Actually, I just said that I revise culture report and he told me, okay, what else? I told him I can take corneal biopsy, and he told me, tell me something less invasive. I don't know why I forget about rescrapping and doing a culture on white media, but it is what happened with me. I forget. So I badly managed this question and I was so nervous probably at this moment. Okay, he gave me this photo after that and asked me, what can you see? I told him that I can see that there is adhesions between the bulbar and the palpebral conjunctiva, and also I can see shallowing of the medial caruncle with fibrosis and keratinization. He asked me, okay, so what's your diagnosis? I told him, my diagnosis is ocular cicatricial pemphigoid. He told me, why you rushed to ocular cicatricial? I told him, okay, I put a differential diagnosis, ocular cicatricial pemphigoid, Stevens-Johnson syndrome, also atopic conjunctivitis, chemical injury, infection with adenoviral infection, trachoma, all of these are causes. He told me, do you know what are the systemic manifestations? I told him of ocular cicatricial pemphigoid. I told him, yes, blisters in the mucous membranes and on the skin. And he asked me what else ocular manifestations about ocular cicatricial pemphigoid. I told him that there is manifestations in the conjunctiva, in the caruncle, fibrosis and keratinization are, as we mentioned, peripheral, severe dryness, corneal, starting from corneal epithelial loss, then ulcer and vascularization, conjunctivalization, keratinization. After that, I think it was up. Okay, and after that we took a break for 4 minutes, and then we went to the last station in the day, which is posterior segment and the glaucoma. And he gave me this the most famous question in glaucoma about a picture of shallow anterior chamber after trabeculectomy, and he asked me about what are the causes of shallow anterior chamber after trabeculectomy. I told him I need to examine the bleb and I need to look for the PI if it is patent or not, and look for the IUB. As in high IUB, I can put a differential diagnosis, maybe suprachoroidal hemorrhage, maybe malignant glaucoma, maybe pupillary blockage. Stopped me and asked me, then what will you, how will you manage the patient if it is a suprachoroidal hemorrhage? I told him I will give the patient IUP lowering measures, He told me what IP lowering medications you will give to the patient. I told him systemic like acetazolamide, and I will give also mannitol, osmotic, and also I can give topical, and I will give the patient steroids to reduce inflammation. He told me, what else will you do to the patient? I stopped. He asked me again, what else? I told him, okay, I can do drainage for this hemorrhage, but not immediately. He told me, yes, not immediately. I told him, yes, after 7 to 14 days, we can do a posterior sclerosis. Then he asked me, how will you manage the patient if it is malignant glaucoma? I told him I can give the patient cycloplegic. He stopped me and asked him, what are the mechanism of action of cycloplegic? Why will you give the cycloplegic in this case? I told him because cycloplegic will dilate the iris and also will decrease the amount of production of aqueous. And he asked me what else. I told him about that we need to deepen the anterior chamber, and I forget. I think I forget the last cause. The last mechanisms, but I think he was waiting for that it will cause posterior displacement of the lens itself. Okay, and then he asked me, what else will you do? I told him if it is the beta, I'll check if the PI is patent or not, and if it's not patent, I will do. If it is patent and the patient is phakic, I'll do anterior hyalidotomy through the PI. Or if it is if he is pseudophakic, I can go posterior capsulotomy and anterior hyalidotomy by HEG laser. Also, I can do argon laser for the ciliary body, or can do cyclophotocoagulation for a quadrant of the ciliary body. And the last resort is to do vitrectomy. He was satisfied, and he during answering, he asked me about the mechanism of action of acetazolamide. I told him it is a carbonic anhydrase inhibitor. So don't forget the basics. The basics is very important. He asked me about how can cycloplegic work, and how can acetazolamide work. I told him that it decreases the synthesis of aqueous, and he asked me about routes of administration. He told him topical or systemic. He told me asking me about types of systemic. I told him oral or parenteral. He asked me about also the dose. I told him 250 milligram every 6 hours. Then he gave me this picture. It was not the same picture. It was a very bad picture with a very bad resolution. So I saw that this red color, which was nasal to the disc in the picture he gave to me, I thought that it is from the bad quality of the picture. So I started to describe that it is glaucomatous disc. I can see that it is 0.8. And he told me what else. I told him the vessels are tortuous little bit. He told me, what if I told you that it is a baby, 2 years old? How can you see all in this photo? What about nasal to the disc? How can you see? How can you describe it? I told him it is red, but I don't know. Yeah, he told me yes. So what's your diagnosis? It is a red color nasal to the disc. I told him maybe choroidal hemangioma. He told me yes. Now it is a case of 2 years old child, glaucoma with choroidal hemangioma. How can you think in this case? I stopped. Yes.
Your question, please.
He asked me about the diagnosis of the case. If it is a case of glaucoma in 2 years old child with choroidal hemangioma.
Yes, look like ketchup fungus. That is
yes,
most probably Starioper syndrome.
Yes, exactly. It's tomato ketchup fungus. Actually, I didn't know the answer in the exam. I told him it is one of neurofibromatosis. He told me you are near the answer, but it is not exactly the answer. I told him, no, I don't know. He told me it is a stage order. Okay. Then he asked me, how will you assess this patient? I told him, I need to take a good history, prenatal, natal, and postnatal, and then I will start to examine this child well. I need to measure the, do refraction to him and to measure the white corneal diameter. And to measure the axial length, I need to examine the whole eye and anterior segment and posterior segment. And I need to measure the IUB. And he asked me, how will you measure the IUB in a 2-year-old child? I told him, we can do under general anesthesia. He told me it's under general anesthesia. And then he asked me about the management. I told him we can start with medications with IUB lowering medications, and I listed them to him, and then we can go, if the cornea is clear, we can do goniotomy. He stopped me and told me, do you think this will work? I told him, actually, I'm thinking that it is a type of refractory glaucoma, and we can do trabeculectomy with glaucoma drainage device. He told me, okay. In CAN scheme, what is written is trabeculectomy combined with trabeculotomy, actually. So I don't know the exact answer in this question, but I answered like this. So now I went to next questions was regarding the retinopathy of prematurity. It was an easy question for me. He asked me about the stages. Anyone know stages of retinopathy of prematurity? Hello.
Yes, there are 5 stages. In
Yes.
stage 1, there will be demarcation line. In stage
Mhm.
2, there will be ridge formation. In stage 3, there will be extraretinal fibrovascular proliferation. In stage 4, it is like extrafoveal and foveal retinal detachment.
Extrafoveal what? Yes.
Retinal
4A
detachment.
and 4B.
Yes. And in
Yes.
5, there will be total retinal detachment.
Yes, exactly. Then he told me, do you know what is plasticis? Do you know? Tell us about plasticis.
Yeah, plasticis, there will be dilatation and tortuosity, dilatation of veins and tortuosity of the arteries.
Yes.
In 8
in two
and more.
quadrants.
Yes.
In 2 quadrants. Also failure of dilatation of the pupil and his media considered plasticis. Okay, now can you tell us when to screen? A baby who was born premature, when to start the screening?
So babies born before the age of 30 to 32 week gestation and weighing less than 1500 should be screened for ROP. The screening should be started 4 to 7 weeks.
Yes, 4 to 7 weeks.
And subsequent review should be 1 to 3 weeks.
Yes, exactly. Then do you know types, type 1 and type 2?
Exactly types, I cannot tell, but
Yes.
there are 2 types. Type 1, it's a severe that need treatment within 48 to 72 hours. So here will be any ROP within zone 1 with plus disease. And the second is in any ROP, I'm not sure.
Stage 3, zone 1.
And the third is, sorry, I'm not getting what we call.
Stage 2 or 3, zone 2, plus disease. Okay. So the question was like this: 1 to 3. I told them that there are 2 types, type 1 and type 2. I treat type 1, and I told him the characteristics of type 1. Then he asked me about vitreous hemorrhage. He told me, what are signs of vitreous hemorrhage? I heard the question, what are signs of vitreous hemorrhage? Sites. of vitreous hemorrhage. So I was confused. What is this cause? I told him vitreous hemorrhage maybe introgel, posterior, anterior. What is? He told me no signs. Yeah, I told him yes, maybe just his media and flutter and his media, or I can see strands of blood, or I cannot see the fundus, complete obstruction of the fundus view. He asked me, okay, what are the causes of vitreous hemorrhage that you know? I started to list a lot of causes, starting from proliferative retinopathy, diabetic retinopathy, central vein occlusion, hypertension, valsalva, ruptured macroaneurysm, BCV, CNV. He told me, okay, and what are the investigations you will do for this patient if you cannot see the fundus? I told him, no, I told him, if I can see the fundus, I can do fluorescein angiography. If I cannot see the fundus, I can do B-scan, and to look for the retina if it is in place or not. Then he asked me about the management. I told him I manage the patient according to the cause. So if the cause is, for example, diabetic retinopathy, and I can see the fundus, so I can start doing PRP. If I cannot see the fundus, I can wait until and observe the patient. Following this patient with B-scan to make sure that the retina is in place, and waiting for resolution. If there is no resolution after 1 month in diabetic type 1 or 3 months in diabetic type 2, I can go for vitrectomy. Then he gave me this photo and he asked me to describe. And I started to describe the photo and mention about these angioid streaks found in the photo. He asked me about the associations. I told him this mnemonic. Pepsi, I didn't tell him the Pepsi, but I told him this is pseudoxanthoma elasticum, like this photo, because there was a bod orange, as you see here, temporally, there is a bod orange. I told him pseudoxanthoma elasticum. I don't tell him Ehlers-Danlos syndrome till the end. I told him packet disease and thalassemia and also sickle cell anemia and idiopathic causes. And he kept asking me what else. I told him that Ehlers-Danlos syndrome is controversial. He told me no, it can cause angioid streaks. So he asked me about the most common complication. I told him it can threaten the macula if it extended to the macula and affects the vision, or it can develop CNV, choroidal neovascularization on top of it. He told me, how will you manage? I told him I will inject intravitreal anti-VEGF. He asked me about types of anti-VEGF. I told him. And then he asked me, how will you investigate? Anyone know types of anti-VEGF? Anyone can answer? Hello? Okay. There are several types of anti-VEGF. We have bevacizumab and ranibizumab and Eylea, which is aflibercept, and we have faricimab also. I told him about types, and he asked me then, how will you investigate for CNV? I told him I can do fundus fluorescein angiography and OCT. He told me what else. I told him indocyanine green. He was satisfied with my answer. And he told me now it's up, calm down and drink some water. Wait until the bell. And the Viva day was up now. And about 60 to 70% of the stress is has gone, because I am not a good storyteller. Actually, I am not a good. I have a bad memory. So a lot of information that we carry when we are going to the Viva day, and I was worried about, I cannot remember all of this. How can I remember all of this information? So after Viva Day, my stress got relieved. Most of my stress got relieved. And there was a day between the Viva Day and OSCE Day. As I mentioned to you, we were booking the same hotel. A group of us were booking at the same hotel. So we started after the exam, after taking a break, we started at the evening to revise with each other the common scenarios that can come in the OSCE Day and the clinical examinations technique and how can we how can we practice it properly. And one of our colleagues got a hurdle to us and we started to practice on it. And we did all the examinations technique. We kept practicing it with each other until we masterized it well. And we went to the second day, which is OSCE Day. I started my exam by neuro and motility station. I met an Egyptian neuro-ophthalmologist in this station. I know that he is very meticulous, so I got some worry. And I started to disinfect my hand, and I stopped in front of the patient. He asked me to examine the pupil. The right pupil was dilated, fixed. The right eye was extropic and it was cataractus. The left eye was reactive. I started by doing an inspection in light. I told him that there is a dilated pupil, there is anisocoria, and no heterochromia, and I need to switch off lights. They switched off lights to me, and I inspected the patient again. I told him still the right eye is dilated and still there is anisocoria. I started by doing the light reflex. I started to do light reflex for the right eye. It was completely reactive. The left eye was reactive. And I did the consensual reflex to the left eye. And I did the direct reflex also to the left eye. And I started to do swinging reflex. When I did swinging reflex, I saw that there is relative afferent pupillary defect. He asked me, how can you know that there is a relative afferent pupillary defect here in this case? I told him that I need one pupil to examine the both optic nerves. So I don't need more than one pupil. So I can inspect the pupil and do relative afferent pupillary defect to the left eye. And go to, while swinging the light to the right eye, I can see that there is dilatation. When I am inspecting the left eye, there is dilatation. So I can say that there is relative afferent pupillary defect. He asked me, do you know the meaning of relative afferent pupillary defect? Yes, I told him that there is a difference in pupillary response between two eyes due to affection of the optic nerve or due to massive retinal disease. He told me, okay, go to the next case, was doing type 1. I started to and do motility. I asked him, shall I do cover and cover? No, he told me no, go for motility. I started to do pursuits. There was limitation in abduction with narrowing in palpebral fissure of the left eye. I told him it is doing type 1. He told me, go on the motility. I don't know. I don't want to diagnose. I proceeded. Actually, I did a big mistake. I think it is a big mistake. After finishing pursuits, I didn't tell the examiner that I wanted to do duction. I didn't do duction for this. Okay, and he told me, what do you want to do next? I told him saccades and conversions. He told me, okay, proceed. And I did saccades and conversions as we learned before. He told me, okay, go to the next case and do cover and cover test. All the neurology was like this, doing tests, no discussion, no diagnosis, no anything. He just wanted to see you doing the proper examination. So he asked me to do cover and cover test. There was right esotropia, while the left eye, there is no movement. He told me, He asked me to do cover and cover for when I tried to use target. He told me, no. I fixed the target on the wall and asked the patient to look at it. Okay, I told him that I asked the patient before starting this test, can you see my target? Can you see my target? She told me yes. I started to do the test and he asked me, do you think it is committant or incommittant? I told him it is incommittant squint. He told me why. I told him because I can see that the secondary angle of deviation is more than the primary angle of deviation. He asked me, then how can you diagnose incommittant squint? Also by cover test, by another way. I didn't get the question. I told him I need to do motility to answer this question. He told me no. After the exam, I knew from another college that I have to tell the examiners that I need to do cover and cover test in 9 cases. Okay. The last case was an old man, and he asked me to examine the visual field of the left eye. I started to ask the patient, can you see my face? Is there any defect in my face? And then I started to do finger projections in 4 quadrants. When I was doing finger projections in 4 quadrants, I was covering the left eye. He asked me why you are covering your left eye. I told him, okay, no need. He told me, yes, no need, don't confuse yourself. Just when you are doing the test. Then I hold my white pen. I asked for a white pen. He was looking for one. Then I hold mine. I was carrying my white and red pens to the exam. I used mine and I started to do the test. When I started to do the test, I did 1 quadrant, the next quadrant, and then the bell rang, and this station was up here. Then I went to, there are also about 4 minutes break. Then you can go to the next station, which was oculoplasty station. The first case was a young girl with bilateral congenital ptosis. I started to tell him the findings that I can see. And when I was telling him the findings, I told him that the palpebral fissure of the right eye is narrower than the left eye. And I told him also that there is a scar in the upper lid of the right eye, and I cannot see any crease and or a scar in the left eye. And so I told him that it seems that the right eye is corrected by surgery and the left eye isn't corrected by surgery. He asked me then, what will you do next? I told him I need to do my measurements of ptosis. I started to do all of my measurements, and by measurements, I find that the left eye is narrower than the right eye, not wider, as I mentioned before. He told me, you mentioned that the right eye is narrower. I told him now I wanted to correct myself because by the measurements confirmed that the left eye is narrower. He told me, okay, what else you want to do? I told him about the corneal sensation. I wanted to test lag ophthalmos. He told me, show me. I showed him how I can test lag ophthalmos. He told me also what else you can do. I told him I wanted to look for Marcus gun. He told me, show me. I asked the patient to move her lower jaw from side to side. He asked me, I told him also I wanted to see Bell's phenomena. He told me, show me, and I did. And that's it. And then he told me, you mentioned that levator excursion is 8 millimeters. So what will you do for this patient? I told him that, anyone know? What will we do? I feel you got sleepy now. So I need someone to tell me. What is your decision now regarding this surgery if the levator excursion is 8 millimeters?
I think with 8
Anyone?
millimeters, good to do the levator resection.
Yes, levator resection. Then he asked me, what is the number at which you will change your decision? I told him 4 millimeter. He asked me, what will you do then? I told him, I can do frontalis slim.
Yes.
Yes. After that, there was a case of complete ptosis in one eye with severe enophthalmos. And I described what I see and the asymmetry I can see. And then he asked me, what will you what you wanted to do next? I told him I want to elevate this lid and see what happened beneath it. He told me yes. Before this station, he asked me to disinfect your hand. So please don't forget, especially if you are trying to touch the patient, like in this station. I disinfected my hand before. Actually, I was disinfecting my hand, but in this station, he asked me before I am going to with alcohol. Okay. And then I elevated the eyelid and I see the suture of post-enucleation. And I told him what I can see. I told him that there is asymmetry and it is a post-enucleation. He told me, what is the different scenario? What are you expecting to elevate the eyelid to find? I told him it may be cysis bulbi, not enucleation. He told me yes. Okay, then what else you wanted to do? I told him I want to inspect formesis. There was shortening in the formesis. I told him it is post-enucleation contracted socket syndrome. He told me why did this happen? I told him because this boy doesn't receive a good replacement of the volume or a good implant volume after enucleation. So fibrosis started and the shortening of the formesis, as we mentioned. And he told me, then how can you correct this situation? I told him we need to correct the volume of the implant, and also we need to reform the formesis again by a graft from buccal mucosa or whatever. And then we need to put a good prosthetic shell, conformer first, and then a good prosthetic shell. He told me then, well, how many operations? It was a tricky question. He told me, how many operations do you think this boy will have? I started to think in a loud voice, and I mentioned, yes, I need to put a good implant, I need to reform the formesis, and I need to put a prosthetic shell. It is 2 operations or 1 operations. He told me, what about ptosis? Yes, he was expecting that I'd say I'll operate ptosis, and this was the trick. I told him, no, at this moment I'll measure the levator execution. I think the best answer is I wanted to evaluate after correction of the volume, and he was looking for this. Okay. Then he asked me to go for the 3rd case. He was an old man with bilateral dermatochalesis. I stayed away from the patient, and he stared at me, and in a firm voice, he told me, go and hold your torch and inspect the upper eye in this box. Okay, so I went to the patient and I inspected the upper eyelid with my torch, and I found that there is an extra low flashes, distichiasis, and there is also entropy. He told me, why do you think this old patient get upper lid entropy? I told him mostly it is a case of trachoma, cicatricial entropy due to trachoma. And I finished the oculoplasty station. Then I went to the anterior segment station. There was a case in the state lab. He asked me to inspect the left eye. There was left eye pseudo-exfoliation. The patient was pseudophakic, and there was tremulous iris. He asked me about the precautions I wanted to take in phaco operation of this patient with pseudo-exfoliation, pre and intraoperatively. Anyone know what are the precautions?
Yes, in the pseudo-exfoliation cases, the preoperatively, because they are difficult to dilate. So prior to that, we can start the atropine 2 days before, and peroperatively we can add the phenylephrine. And secondly, because the zonules are quite like laxity and they are weak, so we need to keep the CTR ring, and as well as the other options of lenses like anterior segment and
Yes.
ACI and
Yes.
yes, these we should have kept them at place while we are doing surgery, and during and we need to also tell the patient about the possibilities of, because of the pseudo exfoliation there can be the certain chances of complications like PCR, so the patient should be informed before too also. And while
Yes.
doing the surgery we should be very careful while handling, especially
Yes,
because of
exactly.
so we need to take the precautions, and we need to do this phaco setting, the low phaco setting, and it's also important to do it on the same day when the posterior segment surgeons are also available. It is better to do that.
Yes, exactly. So I told him as you told us now, and while I am inspecting, I told him that the anterior chamber is deep. Then he asked me to inspect the right eye. I inspected the right eye, and I told him I cannot see any signs of pseudo-exfoliation in the right eye, but the patient is pseudophakic. So he asked me, you told me that the angle is deep in the left eye, right? Yeah. You tell me now, how can you measure the angle? I showed him the von Herrick method, and I measured the angle. He told me then when you say it is closed angle and when you say it is open angle. I think after I got out from the exam, my colleague mentioned to me that this patient in the right eye has had yet capsulotomy, insufficient yet capsulotomy, and I think the patient was looking for this, but I didn't mention, so he tried to give me another help. He gave me the question of measuring the AC depth. Okay, then the case, they asked the case to go, and they set another case.
Sorry, Dr. Heba.
And
Sorry, Dr. Heba, I just want to interrupt you. What are you saying that he was actually asking you about measuring the depth of anterior chamber, and
yes.
I didn't get what you were saying.
Yes, I mentioned that there was a yak capsulotomy I didn't mention about. So,
Okay.
Yeah, my colleague mentioned this to me after the exam. So I think the examiner when he found me didn't mention about this yak capsulotomy. He tried to give me another clue to pass. He asked me to measure the anterior chamber.
Okay, thank you.
Angle. So I showed him the von Herrick technique. So I wanted to tell you that how much techniques or proper techniques can save your passing in the exam. Even your performance is down in some cases. Okay. Then I took another case. There was right PKB, and I started to describe everything about sutures and the graft, and there was also a patent BR. I didn't mention here that there was a patent big, large peripheral iridotomy, and there was no signs of trabeculectomy, and the patient was fecal. And he, after I mentioned all the findings of the right eye, he told me now inspect the left eye. I inspected the left eye. It was also phakic, but with anterior chamber eye. And also there was a large patent peripheral iridotomy. So he asked me now, what do you expect the scenario of this case? I told him that I'm expecting that this case was has undergone implanting anterior chamber IOL bilaterally, but he got corneal decompensation in the right eye. So he went to PKB. He told me, okay, why he implanted anterior chamber IOL, why he is faking. I told him because maybe he is a high myopic patient. He asked me now, okay, what are the advantages and disadvantages of PKB and that? Anyone know to answer this question? Anyone can answer what are the advantages of PKB over DALC and what are the advantages of DALC over PKB?
With the PKP, it's like the visual rehabilitation or the visual recovery is more better than
Yes, yes.
DALC is like more technique is required as compared to PKP because it's a descendant membrane stripping, so very expert person is required to that, and that's I can think of.
Okay, what else? What regarding to the interface? It is the
Yes.
most important yes point he was looking for.
The DALC is better than PKP in the interface because in the PKP there are more chances of it filtrates and reaction because and rejection and failure, and it will be less in case of DALC.
Yes, the rejection is higher in PKB, but the interface you may get his interface more in DALC. Okay, because there is interface. No, PKB no interface. You replace the whole cornea. Okay, the interface is in DALC. Okay, he was looking for this answer. And then he gave me a third case, which I failed to diagnose. It was emulsified silicon in the AC. Not like the inverted hypopion, but like his in the AC. It is a very famous video. I saw it several times on Facebook and YouTube, but I failed to diagnose in the exam. Okay, no worries. I passed now. Then I went to the posterior segment. Yes, I went to the posterior segment station. He gave me, he asked me to sit in the slit lamp, and he asked me to examine the right eye. And there were 90D and 78D, and he asked me to choose what I like to choose. I chose 90. Okay, and I started to inspect the patients from the anterior segment first. I saw that there is rubiosis iletis. I mentioned about, he told me, go to the posterior segment. I started to describe that is optic disc atrophy. I forget to mention glaucomatous, I mentioned it is pale and atrophied optic disc, and there is a fibrous band superiorly with extensive laser marks. He asked me about my diagnosis. I started to mention that there is signs of diabetic retinopathy, and also there is attractional band, so it is advanced diabetic eye disease. So after he told me what are the systemic risk factors, other systemic risk factors, so you can get this case. I mentioned about hypertension, hyperlipidemia, smoking, renal disease. She asked me, now tell me what's your management. I started from history, investigations, and all of this. She stressed on the investigations. I mentioned about OSCE and the FRCS. I think I forget to mention about systemic investigations in this question, and I remembered after the exam that I did. Okay, and she asked me, so what's your decision? I told her my decision will be barzoplantar vitrectomy. Then she told me to go to the next case, it was indirect ophthalmoscope. I started to set the ophthalmoscope, and when I put the lens, I saw that it is a case of high myopia, high myopic fundus. I could see that there is pale disc, peripapillary atrophy. Then after inspection for a while, I could see that there is silicone reflex. I mentioned about it, and then I stopped. I didn't see what happened in the periphery. I cannot mention about the periphery, what is happening. Okay. Okay, I felt like I lost this station now. I cannot complete my examination, and I cannot tell him. He asked me what can you inspect in the periphery. I suspected from his question that maybe a bucket. Okay, so I asked the patient to look downward, and while she was looking downward, I saw stitches. It was a new bucket, so I saw stitches. Then to confirm my diagnosis, I gently put my little finger while I am putting the 20D diopter lens. I put my little finger. I felt the buckle. Okay, I told her there is a buckle. He told me what type of buckle. I told him circumferential. He asked me about the diagnosis. I told him this patient is high myopia, and she got recurrent retinal detachment, so she siliconized, and also she got a buckle. And then he asked me what do you want to examine next? I stopped. I wanted to examine what else. I stopped the periphery and the anterior segment and the cornea and all of things. I want to measure the IOP. I wanted to do motility. And then he kept asking what else, and at the last I remembered, yes, I wanted to examine the another eye. Okay, the other eye. So he told me, yes, what will you examine the other eye? I told him I wanted to look for any peripheral degenerations due to myopia or any signs of retinal break or retinal detachment. He told me, okay, and the time was up here, and I finished all my exam. As you see, I was not perfect at all. My level was average. I was not so good, not so bad, but not so perfect. So I did a lot of mistakes. But I think they are evaluating your overall performance. And actually, all the examiners tried to help me to pass the hard questions that I faced in the exam. When I stopped working several times, they tried to give me clues to pass this point. All of them were kind, were friendly in their discussion. They are not trying to trick you or to make you tell them the wrong answer. No, they are trying all the time to lead you to the correct answer in a way or another. They are trying with you to say the perfect answer. Okay. Even if you are trying to not do, they are trying to extract the good answer from you, especially if they are feeling that you are studying well, you are preparing well to the exam, and you are just stressed or confused or something like this. In the Viva, co-examiner told me, stop, calm down, no worries, take a breath. Okay, 2 examiners. And also in the OSCE, as you saw with me in my presentation, all of them tried to help me, all of them tried to give me hints to proceed. So I wanted to tell you that it is normal to not be perfect. You have not to be perfect to pass the exam, and you have not to be you have not to know everything in ophthalmology. No, but you have to know the basics well. Okay, and please let the examiner help you. If you are studying well and preparing well, so you can take the help. If you are not, you cannot take the help. Whatever the examiner does to you to help you, he cannot. So please let him help you by good preparation before the exam, so that if you forget anything in the exam due to stress, due to confusion, due to you are a human and you can forget, so he can help you. Okay. I finished now my presentation, and I'm happy to conduct this presentation to you today. And I'll be happy if any one of you need any help and want to contact me. This is my WhatsApp number. You can contact me anytime. I can help you as much as I can. Anyone want to ask anything?
Actually, I want to thank you a lot for your great effort, for your sincere presentation, for trying to help us, for putting your presentation for us in the group, for sharing it as document, and for presenting this. I know you're so tight, your time is so tight with your very young kids, and you seem very dedicated till you didn't have a breath even today. Thanks a lot for your time, Heba. Thanks a
Thank
lot.
you.
Just get some
you.
water, please. Thank you.
Thank you.
So much. Thank you so much. It was a great help. Thank you so much.
Thank
Thank
you.
you, Dr.
I hope you got the maximum benefit I wanted to conduct through this presentation. Thank you.
Thank you so
Thank
much.
you.